Hello, everybody, and welcome to today's webcast on listening to the voice of the patient using multiple feedback methods to complement consumer assessment of healthcare providers and systems, or CAHPS survey data. My name is Dale Schaller, and I'm really pleased to be your moderator on today's webcast, which is presented by the AHRQ, or Agency for Healthcare Research and Quality's CAHPS User Network. Next slide, please. Just a few quick housekeeping details. If you have any audio issues with your computer, you can ask Zoom to call you back by entering that information at the appropriate place on the legend on the bottom of your screen, or you can actually call into Zoom yourself by finding the phone number and the meeting ID number on the site. If you have a poor connection, you can always try to log off and log back in. And most important, to have your question posed for our panelists today, just type it into the Q&A icon, and we will do our best to answer your questions at that portion of the webcast today. Just as a reminder, today's webcast will not have the raise hand or chat features operational. And finally, today's webcast has an event site, which you should have been given in your confirmation email for the registration, which is at events, events.westat.com/CAHPS. And there you can find today's slides. You can look at the agenda and learn more about the speakers on today's webcast. Next slide, please. So I'm really excited about our agenda for today, which will begin with a brief overview of AHRQ's CAHPS program, which will include a look at various methods that can be used to listen to the patient voice and complementary to existing CAHPS survey data that you may be collecting. We'll then have a chance to look at a few case examples of patient feedback methods that have been used in two settings. One, a large health plan with multiple practice sites serving predominantly Medicaid and Medicare enrollees, and then by the Veterans Health Administration with multiple sites and facilities across the country. We'll then have an opportunity to have a panel discussion with our two presenters before we move into your questions and answers. And with that, we can turn now to who are our speakers today, which will begin with Caren Ginsberg, who directs the CAHPS program and the Surveys on Patient Safety Culture, or SOPS program, at AHRQ's Center for Quality Improvement in Patient Safety. And Caren will be followed by Nicole, who is the founder of Ignite HX for Health Human Experience, and former Chief Experience Officer at Caren. Nicole will be followed by Donna Richardson with the U.S. Department of Veterans Affairs, who will talk about her experience as a customer experience and outcome supervisor. And with that, I'm pleased to turn it over to you, Caren.
Hello, and thank you for joining us today to discuss the patient's voice and understanding patient experiences with care. We're delighted to bring you a panel discussion today with time for questions and answers at the end. Before we start the panel discussion, though, I'd like to start with a brief background on the CAHPS program, patient experience, and AHRQ's role in the CAHPS program. On the next slide, please. So the Agency for Healthcare Research and Quality, or AHRQ, is a research and development agency of the U.S. Department of Health and Human Services. And what we do is we generate research and tools and data using best practices that can be used for improving the quality and the safety of the U.S. healthcare system. The CAHPS program has been funded by AHRQ for 29 years. And through that time, we've advanced the science and improvement of patient experiences with their healthcare through developing validated surveys and supplemental items, including narrative or text items for patients that can be used in conjunction with CAHPS surveys. We've developed quality improvement resources, such as the Ambulatory Care Improvement Guide. We host voluntary databases for quality improvement purposes for selected CAHPS surveys. And you can find our data on the AHRQ Data Tools website. And we conduct research that's advanced the science of patient experience measurement and improvement. All of our materials are available for you at no cost. You can download them from our website, and we provide technical assistance for the CAHPS tools and resources also at no cost to you. On the next slide, I'd like to define patient experience. Patient experience is what actually happens to a patient in a healthcare setting or with a health plan, or how often something happened to that patient. Patient experience encompasses the range of interactions that patients have with the healthcare system. And this slide shows elements of patient experience that are captured on CAHPS surveys. Patient experience is different from patient satisfaction. They're often used interchangeably, but they're really not the same thing. Patient satisfaction measures how patients feel about their healthcare and whether their expectations for their healthcare encounter were met. Patient experience measures are objective and actionable for quality improvement, whereas patient satisfaction measures are subjective and they have a different meaning and purpose entirely. And the next slide, please. So why do we measure patient experience? Well, patient experience is something we want to really understand as our patients walk through the healthcare system and receive care. But also patient experience is, there's extensive evidence documenting the relationship between patient experience and health outcomes and business outcomes. And so those are other reasons to measure patient experience, to document these associations. We could actually do an entire webcast just on discussing health outcomes and business outcomes as they relate to patient experience. On the next slide, please. This slide shows different ways to collect patient experience information. CAHPS surveys are only one way to collect patient experience information, but there are lots of other ways as well. Other quantitatively focused methods include proprietary surveys, rapid cycle surveys. Qualitatively focused methods include the patient narratives I described earlier, or focus groups, or patient shadowing or journey mapping. And patient partnerships can also provide information, such as patient and family advisory committees. I'd like to point out that all of these methods add different perspective to patient experience. They're all useful in understanding the patient experience. The next slide, please. I'd like to think about all of these methods as belonging under the patient experience umbrella. All of these are ways of collecting patient experience information. They all contribute to a clearer picture of what happens to patients in their healthcare encounters. And there's a role for each of these sources in understanding the patient experience. And this is how you get a handle on patient experience. On the next slide, please. So we're going to talk today about using the patient's voice to understand patient experience. And I'd like to point out something that I get questions about all the time, which is whether CAHPS surveys collect information using the patient's voice in the survey development. And they do. All CAHPS survey development projects start with asking the patients about what's important to measure and report, and their patient answers form the basis for our surveys. So I just want to make sure that everybody understands that. And with that, I'm going to turn this over to Dale for our panel discussion. Thank you again.
Thank you, Caren. It was a really, really helpful introduction and background to our panel discussion. And we'll begin now with Nicole Cable discussing her experience with CareMax, and then follow with Donna. Go ahead.
Thank you, Dale. Next slide. So I just want to give a brief background to the organization, just so that we can put it in context. So at the time that I was a CXO, we operated 62 medical practices in 11 states and partnered with over 2,000 primary care providers. 93,000 of our members were Medicare Advantage, and we had 110 members that were part of the Medicare Shared Savings Program and the ACO REACH, which is Realizing Equity, Access, and Community Health. We had over 203,000 total value-based care members, and had the largest accountable care, second largest accountable care organization in the country based on beneficiaries, and had a total of 245,000 value-based care members. Our patient population was unique. Over 61% of our patients actually were eligible for Medicaid and Medicare. They were duals. 75% of our patients actually identified as African American, Latino, or Indigenous. And of those patients, over 40% of our patients had either 4 or more chronic conditions. So this really was a very vulnerable population that had some health issues. And so we really wanted to make sure that we were delivering on our value proposition for delivering better care. Next slide. So the case study, when I came in as the Chief Experience Officer, was to capture the voice of the customer. So we actually created a VOC program, Voice of the Customer. The scope was to look at the organization in its entirety, creating an enterprise feedback management system, because we discovered that we were losing patients through disenrollments, or what we call customer churn. As we became a publicly traded company, we were growing through a lot of mergers and acquisitions, and did not have a lot of stickiness with our patients staying with our practices. So that was a priority, was to lower that churn rate. So that was one of the objectives. Another was to gain real insight and feedback, and to identify areas of opportunity, just so we could set up process improvement plans and help improve customer experience overall. And then we wanted to centralize the data, have all of the data that we were collecting in one repository that we could share with our providers, our staff, and then be able to move the needle on the reduction of customer churn. So the tools that we used were the clinician and group CAHPS survey. We did rapid improvement events, observations, focus groups, current and former patients. We also had patient and family advisors, point of service surveys, so surveying our customers at the point of service when they were in our practices, and journey mapping. But not just journey mapping for our patients and their families, but also journey mapping for our providers, as well as our team members, because their experiences also influence the voice of the customer. And then we asked narrative questions. We actually leveraged some of the questions that were that are listed out on the AHRQ website for the surveys that we perform under clinician and group. So after about 8 or 9 months, we started seeing the needle. There was a lot of other work that went on that informed our strategy, and then the tactics within that strategy. But the results were pretty successful for us. We actually were able to reduce the customer churn rate all the way down to 3.4, and at the lowest we were at 1.9. We then started to see the disenrollment rate sit at around 3 or below for the rest of its for the time that we had moved forward. And so that was really successful for us, because that was something that our CEO wanted us to do, was to get our disenrollment rate down to at least a single-digit number. We also were 5 stars for most of our practices, except those that we were acquiring. So then we were able to work with those practices and get them to 5 stars. We did leverage the CGCAHPS survey. So we did look at provider rating, and our patients were 96% satisfied with the providers that we had in our practices. We also leveraged a question around the patients being seen within 15 minutes. While it was not a part of our original survey, our healthcare plan partners really wanted to know what the perception was of our patients that we were serving and seeing them. And over 93% of our patients actually said they were seen within 15 minutes of their arrival time. And lastly, we did track M.P.A. We did M.P.A. at the point of service, and we also did M.P.A. within our CGCAHPS survey tool. And we were at 96.7% for that as well. So now I'd like to turn it over to my colleague, Donna, so that she can share her information with you as well. Next slide.
Thank you, Nicole. Hi, everyone. I'm Donna Richardson. I do work in the Veterans Experience Office of VA, and I have the pleasure of talking about the work we are doing in collaboration with the Veterans Health Administration in VA. As you can see, we look at the experience holistically here, in the sense that for VA, patient experience means that it is the sum of all of our interactions shaped by the organization's culture that influences veterans and their families' perceptions along their healthcare journey. When we break that down, it is every interaction they have, whether you are calling for an appointment and that interaction over the phone, you are parking in our parking lots, entering the building and navigating to your appointment, or you are receiving the follow-up that you require from your clinical appointment. That culture for us is very important. We have a very specific patient population, those veterans that earned their services with VA, and veterans are in their voice of the veteran is included in that culture. That culture is something you feel, and we want it to be welcoming for everyone. And last but not least, it is their perception of the experience, their perception of the encounter and the interaction that matters here. At VA, for patient experience, we are, as you see here on the screen, a bit of a employee experience is included in this. You know, we have the saying, happy employees provide better customer service. So we look at the employee surveys that are available for us, as well as a variety of other surveys and opportunities that complement the CAHPS family of surveys. I will say in VA, we call it the Survey of Healthcare Experiences of Patients. So we call them SHEP. The SHEP team is fabulous, and they are the ones that conduct and aggregate all of the CAHPS and HCAHPS information for us. So we are lucky that we have their team. But we do use all these complementary data sets as well to really understand the process of our patients. Next slide. So this is a great example of one of many tools and products that we have available to help understand our patient journeys. I apologize, I will probably slip and say veteran journey, patient journey. They are one and the same for us. But we even say the voice of instead of the voice of the veteran rather than the voice of the customer sometimes. But for us in the Veterans Experience Office, we leverage data tools, technology, and engagements to enable VA to be a leading customer experience organization in government. So service members, veterans, their families, caregivers, and survivors choose VA for their care. And one of the things that we leverage is we use a human-centered design approach to problem solving, where we are designing solutions and identifying the pain points of our customer, of our patients, of our veterans, by involving them in all steps of our problem solving process. Through HCD, we are better able to understand the moments that matter most to them in their journey and interactions with VA specifically. And this allows us to understand and complement, say, this journey map around outpatient primary care appointments with the CAHPS family of surveys that we have in data. This is a great example of an artifact created through human-centered design. This was actually created, this was probably the first journey map that we did produce, the outpatient patient experience map, where it identified the 5 phases of those interactions, the moments that matter most, what were the bright spots that those patients have with VA, those pain points. And from here, what we are able to do is with those moments that matter most, we then design surveys to complement and see how we're doing on these measures. And in fact, you'll note, what should be measured down at the bottom. You'll see some themes around ease, effectiveness, and emotion. All of those hopefully leading to a prominent overall trust. Those are very important measures for us. And we use those and sort of this methodology to complement the work that we're doing with the CAHPS family of surveys. I think that's good for now. So if you don't mind, I'm going to go next slide and hand it over to Dale.
Thank you, Donna, and you, Nicole, for some very, very helpful kind of snapshots of your experience in your organizations, respectively, on using multiple feedback methods. So we're now going to have this discussion. We're going to move away from slides and just focus on each other through the spotlight technique here. Nicole, I see you. And Don, I see you. Caren, are you going to join us too? We'll see. But I thought maybe a good way to sort of kick off our discussion is to ask you both in turn to sort of address the kind of overarching question of how do you, knowing that you do collect CAHPS survey data, how do you integrate the information you derive from those surveys with the other kinds of feedback methods that you've described? Go ahead, Nicole.
So for us, and so what I didn't allude to is I'm familiar with HCAHPS because I had it for 8 years, and CAHPS for the healthcare plan. So for this conversation, I'll just focus on what we did for the primary care practice group that I worked for. We actually collected data from multiple sources, including surveys from our team members, even things that were on the internet. So if you were commenting about my organization, we were capturing it. And we put it into a data warehouse. And so in that data warehouse, all that information was aggregated, and we had a data scientist actually help us structure it. And then we would pull that information out, and then we would share it with our practices, with the regionals, the center administrators, even the providers. And this information was looked at through different venues. So if it was during the huddles that we were having in the mornings, or just during our town hall meetings, we were constantly sharing that information and collecting all that data, and then being able to synthesize that down to even predictive analytics. So we really took all that data that we were getting and just bringing it into one umbrella.
Nice. Donna, can you address that question too?
Yeah, thanks. I admit we don't yet have one integrated dashboard that consolidates, especially those data points that I just showed in my slide earlier. But we are lucky that we have, when we think of integration of data, we don't just have data and the raw data itself, but we have a lot of reports available. Our chef team, as I mentioned, that runs the CAHPS family of survey for us, they provide not only, the state of the data, here it is, but some really great regressions that allow us to identify where to pinpoint our efforts. They provide reports that are geared towards different audiences, which is really nice. And whether you're frontline employees, your leaders, and across the board, what we're trying to do with integrating the data is really there's 3 things. The first is identifying the bright spots. We want to celebrate our success, highlight and recognize employees, and celebrate those wins. The second thing is what we do with integrating the data is identifying the opportunities. What are those pain points? Where are those improvement for scores? How do we improve? And how do we take process improvement steps on improving those measures? And the third is doing service recovery. Acknowledging our errors and working to make them right, even at a systemic level. If we have identified that, our survey says this is a pain point across one of our networks. I failed to mention, we do have 172 health medical centers, 139 healthcare systems across the country, 9 million veterans seek their care at VA. So for us, it does help to regionalize as well.
Sure.
But we have a lot of reports that allow us to integrate that information and ensure that across the board, all 3 areas of those are being tackled.
That's really helpful from both of you. And I'm just curious to know if, given the various feedback methods that you have, do you ever encounter conflicting information so that maybe the CAHPS surveys are leading you in one direction in terms of your analytics, but you're finding out something different through another way of capturing the voice of the patient or the veteran? So I'm just curious, what do you do? And this was actually a question that came up through the registration as well. The idea of reconciling different sources of information if they don't always sort of just align with each other. Nicole?
Yeah, that happened to us a couple of times. So we do a point of service survey, which includes M.P.S. And so
M.P.S. meaning?
I'm sorry, I forgot. Net Promoter Score. Thank you for
Net
clarifying. I apologize. So we use Net Promoter Score at the point of service. And what we noticed is that we would have higher scores after the patient saw us, but then we actually put the question at the end of our clinician and group survey, and noticed that the scores would be a little off. So what we understood it to be based on focus group, because we didn't talk to patients like, why, why would this happen? And just looking at the data, is that they almost felt like they were captured. And so they kind of had to give like a decent rating when they were coming out of the clinic. Some were honest and gave us lower scores. But once they went through the experience and answered all those different questions around access to provider, the front desk, like all those different things, they would then give us a lower rating.
Interesting, because you
Which
actually
was
had them think about what they actually experienced.
exactly. So when they started thinking about it, it was like, wait a minute. So now, once we, went through that, service recovery kicked in, right? So, and also we learned a lot more about, okay, what we could do differently. So, and they were much more transparent with our team members that were doing the survey because of who we serve. And we asked, going in, the best methodology to survey our population was by phone.
Okay.
So we received a lot more feedback, verbatim comments that we could actually then synthesize and start to improve the services we were delivering. So it was very interesting to see the difference between when you ask it when they first come out versus when they realize and go through the experience, how they really felt about us.
That's very interesting. We've noticed too, particularly in Medicaid surveys, that sometimes ratings are higher than the actual reporting questions on a CAHPS survey, because there's sort of a difference in terms of kind of how you would rate something versus your actual experience. And sometimes the reports are actually quite much lower than the ratings. But Donna, go ahead. What do you do when you find some sources of contradiction, if you do, in your different feedback methods?
Oh, we do on occasion. First thing is probably validate the data. Do you have an appropriate sample size and response rate? Is the information you're looking at accurate? If it's not, encourage focus groups and follow-ups. Reach out to those customers to talk about their conversations. I will say we mostly see this with some of our rapid cycle feedback surveys. So another survey set that complements this. And it comes down to terminology in the sense where we have a free text comment available on those surveys, and you only get 3 options to classify it. You can classify it as a compliment, a concern, or a recommendation. And what we see most often is that recommendation will be flagged, and you might think they'll reference something process improvement, but typically what we see is keep up the good work.
Okay.
I would take that as a compliment, but they are really recommending we keep up the good work.
Yeah. Got it. Very helpful. Nicole, you mentioned in your response to the last question that you found phone surveys were a more effective way of reaching your particular population. And given the fact that you've worked a lot in your CareMax experience with Medicaid and Medicare, can you comment, this is a registration question, about how can you most effectively reach more vulnerable populations to make sure you hear their voice through either technology or digital platforms?
Okay, so that's a good question. I'm going to wear 2 hats. So one from a Medicare Advantage healthcare plan, because we were the 9th largest at the time, and also clinics, because we also had wholly owns as well as CareMax. So when I worked in the plans, I didn't really understand how patients were actually, answering surveys in the sense of what technology worked best for them. And so what I uncovered in this is that a lot of patients that were duals or Medicare Advantage, a lot of them had what you call government issue phones, affectionately called Obama phones. And so through these phones, they have limited minutes. And so we would survey patients all month long. And sometimes they would do text and email. Now, I have to be transparent. Text surveys, I got about 2% back. So very low. Email was lower than that. So phone was the most effective way to get a hold of our patient population. We uncovered, even when we looked at that, we stratified data, that we would have about 90,000 members that did not have anything but a landline. So I really couldn't do anything like text or email, because I would have disenfranchised 90,000 people that might have wanted to give their voice to me and created more healthcare disparities, right? So it really was understanding the patient population, what access did they have what did they have access to? What kind of tools?
Mhm.
If it was a phone or internet, what kind of phone? What kind of internet? Because if they are getting these government minutes, then I knew I needed to reach out to them within the first, 10 days of the month. Because as you got further down in the month, the minutes lessened, they were less likely to respond to us. Right. You think about when you call your provider, how many minutes does it take you to get a hold of someone before you go through the IVR? Those are valuable minutes to someone who is vulnerable and needs that phone for the entire month. So that was something that we really never understood until we started diving deeper into the data and talking to our customers. So once we understood what type of phones they had, then we knew what kind of outreach we needed to have and what kind of outreach we needed to perform. And then lastly, we asked them, how do you want to be communicated to? Do you want to do the survey through phone or text or email? And the lion's share of our members, our patients would say, we want to be called. And I think it's also because a lot of our patients, English was not their primary language.
Mhm.
So having someone that spoke their language in Spanish and sometimes the same dialect actually got more surveys completed, and we got a more true representation of the services that we were delivering. So I think you really just have to pay attention to who your patients are,
Yeah.
what tools they can use, and what literacy levels that they have. If they have issues with prose and numeracy, you have to make sure you take your time and go through that survey appropriately.
My takeaway, and that's a really, really helpful sort of review of how you dealt with that issue. So really understanding your population, the methods that work most effectively with them, and then tailoring your outreach to accomplish that sounds like a takeaway on that. And Donna, just really quickly, given your population obviously is in many cases elderly, given that they're veterans, not all, but have you found particular modes work better for the VA, or does that just sort of depend regionally, or how can you?
So I will say we are really lucky. Veterans want to give us feedback on their healthcare system.
Okay.
The paper surveys, the CAHPS family of surveys, we average a 30% response rate. Our electronic rapid cycle feedback surveys come at 15, 20%. Because we give veterans ownership in their healthcare. And for us, what we have found interesting is that our older populations are more tech savvy, in the sense where we have a higher response rate of veterans over the age of 70 responding to our email surveys than the veterans under 40. So it has been very interesting in seeing who is responding. But I agree with Nicole's first statement and ask for their preference. How do you want to respond to surveys and feedback?
Yes.
Could
Okay.
I ask Nicole a question about this? I don't think you've mentioned it. Could you talk about the response rates by each mode of administration?
Yes. So for us, our patients were, most of our patients, English is not the primary. So when we first started emailing this, because we tried, email and text first. So when we did the text messages, we got about 2% response rate. And we sent surveys to everybody. So we wanted to see who we could get. And then when we started doing email, it was less than 1, honestly. They didn't click on it and go to the survey and complete it. And then the majority of our survey results were through phone. And when we would perform the focus groups, it was very interesting. Our patients, some of them they just didn't have the literacy levels to complete those surveys, because our membership is very vulnerable. Some are homeless. So, trying to think they're going to sit and do the text, it's much easier for them to actually just talk to someone. We even had a situation where a patient said they were suicidal during one of our surveys. And that was the first. And we had to, rapidly address that situation and create a process around it moving forward, because we'd never experienced anything like that before. So for us, I think they just wanted to talk. And I think it just was an easier way for them to do it. And we know that loneliness and isolation is becoming bigger and a bigger issue now. And there are some surveys out there saying that about 70% of people that call contact centers don't even have an issue. They just want to talk to somebody because they're lonely. So it just made sense for our population for us to make those phone calls versus trying to do those other modes of admission or transmission.
So I want to turn now to, so we've talked a little bit about gathering feedback from patients through multiple methods and how do you maximize the outreach to get that response. But I want to ask you, Donna, in terms of taking that information that you've integrated through various ways, how do you then use that to actually reach providers and get them to sort of pay attention and to actually do the improvement that this is all about anyway, right? Improving the patient and veteran experience. Can you comment on that?
Yeah, great question. We get that all the time. We've seen success for provider education around the CAHPS results. And just first and foremost, I will also say that one of the mantras in our office is meet them where they're at. So we tailor the conversation, the education to our audience. And so if we are talking to providers, you can't bolt them all together. You know, sometimes a provider responds best to another provider. Having another provider come in and provide fellow clinician coaching about how they have seen benefits from using the data is one way to do it. Another one is validating the data around providing other evidence-based peer-reviewed journals that talk to, as Caren mentioned, you know, showing the value, showing how you can see positive clinical outcomes from focusing on the experience. Sometimes it is putting it in performance plans and that, you know, pay for performance. One thing I will say when it comes to engaging providers, it's a multi-pronged approach. And we're also lucky in VA around, we have the opportunity to do a lot of provider training and just education around patient experience in general. I think we've been very successful in rolling that out over the last few years. Most specifically, we have just recently rolled out a desired VA behaviors. These are like how we put our VA values into action. This is a patient communication model, and it's a great opportunity for us to talk to providers about how we want them to remember these we care behaviors. We care being an acronym for welcome, explain, actively actively listen, respond, and express gratitude. So we already have that open door for that conversation, so we can show them how to show those we care behaviors while we are educating them on that patient communication model and their data.
Very good. Thanks so much. Just a really quick question for clarification. I saw coming in on definition of a rapid cycle survey. Nicole, I think you mentioned that, or was it Donna? Okay, go ahead.
We use those. So it's a really great compliment to hear the voice of your customer. We have at max 15 questions on these surveys. They are based on your interaction you've had with our healthcare system. You may be eligible for one of these surveys where you will get this survey within 2 weeks of your encounter. In fact, if we have your email and file, you called and created had a primary care appointment scheduled on a Tuesday, you will have this survey by Friday. You have 2 weeks to fill that out. In addition to the 15 questions, there is that free text comment box, which is available. We have about 80 of these across our system. So really looking at a variety of outpatient interactions.
Great. One other question that came in through the registration, which I think kind of gets back to reaching the patient, are techniques or strategies for not only how you reach them, Nicole, as you've so eloquently described in terms of, you know, matching their preferred response mode to the way you outreach to them, but how do you get them to actually engage, to encourage them to take the survey once you've reached them? Do you have any sort of tools or strategies for motivating, regardless of the channel? How do you get them to actually respond?
Well, actually, we celebrate what they told us to do. So one of the biggest complaints that we get from patients when it comes to doing a survey, and even myself, is what are you going to do with the data?
Yeah.
You take it, but do you do anything with it? Well, yeah, we do. And so by demonstrating, you know, if a patient told us once that we needed to educate them on how to use technology. Well, guess what? We started doing training classes around technology, and we highlight patient X as the person who came up with this idea. You know, through their survey response, this is what we got. You know, we got this from you. We heard you, we listened, and we acted on that. And we work with marketing to publicize that throughout our practices, to say, yes, your voice does matter. So any processes that we've changed, any improvements that we've made, based on survey results. We share that shamelessly across all the practices, even in the healthcare plan world when I was there. And what it did is it emboldened people to realize that, yes, your voice does matter. They do listen to you, and they're more amped to fill that survey out. Because the biggest pushback was, you're not going to do anything with my data. And I think that's something that we struggle with in healthcare, is letting the patients know that their voices were heard and we did respond.
I've
So
seen
that
that same finding, by the way, on a national consumer poll, that one of the reasons people are skeptical of these kinds of surveys is that they feel that the information they provide isn't really acted upon. So demonstrating that to your patient population. And Donna, can you resonate that? You're nodding your head like,
Oh, it's like Nicole and I planned this. Marketing 101, telling the patients what you're doing with their data. Also leveraging word of mouth, ensuring your veteran and family advisory committees know what you did with the data. I will also say we're the government, so our data is publicly available. You can easily see our data at any time, so the public can hold us accountable there. And if they see a pain point, they will let us know. But also employees, ensure employees understand the data and can tell the patients, hey, we do something with this. We look at this data on a monthly basis. We want to hear your voice about how we can improve your healthcare system.
That's excellent. So we have some time remaining to kind of move to audience questions and your answers. So Mike, thank you. If you could just remind the audience here, and many of you have already been submitting questions as we've gone along, to type your questions, send it into the Q&A icon. We are going to take a look now at a couple of questions that have come in. Several of these have actually been answered. One to you, Nicole, is looking for a little bit more information on your CAHPS work plan in terms of moving from the data that you collect, using any best practices or recommendations to actually achieve. No, I guess you've already answered that question. I'm sorry. We've defined patient experience. Oh, well, in some ways you guys have addressed this, I think, pretty well. People are understandably concerned in health plans, provider organizations, about survey fatigue. And if you've encountered that to the degree that you can sort of provide specific advice on how you address that beyond what you've already described in terms of encouraging feedback and using outreach methods that actually best reach your populations.
If you don't mind, I can tackle that one.
Sure.
So we are lucky that our survey teams do have quarantines in place. So if you've responded to one of these SHEP or CAHPS family of surveys, you are ineligible to receive one for a year. We have enough patient eligibility to get a good sampling from others. For the rapid cycle feedback, so in the sense where this is short, we get your results instantly and act on it. There's a 30-day quarantine, and for healthcare in our system, we have about 80 of those surveys right now. If you respond to one, you are quarantined from any other interactions, because we know if you call primary care, you're also scheduled other appointments, you're following up with specialty, you've had other interactions. So we are very cognizant of that survey fatigue, and we also ask their preferences as well.
Great.
Same here. We have protocols in place that they're not getting over surveyed, and also there are surveys that we can't control. So the healthcare plans do their surveys as well. So we try to make sure that that we don't over survey our patients. Okay.
Donna, this question I think is specifically for you. You talked a lot about using a journey map for mapping your patient's journey. Are there specific tools, or do you have to sort of invent that within the organization? Can you talk about how you constructed that?
I will say there's no one right answer. We originally started this journey with Post-it notes. We interviewed veterans across the country. We all got together to synthesize the data. We hand wrote all of the information and had it up around the conference. It was more than a conference room. So you can do it manually just by that. We've advanced in our technology that, we use Mural right now, really collaborative. It visualizes those Post-it notes for us electronically. And then I'll also add, AI has been a really nice addition to this too, for synthesizing feedback, especially the type of feedback that we're talking about, in the sense where it can help us identify and roll up those themes and that information for us.
Yeah, really, that's really helpful. So Nicole, you mentioned doing service recovery. You talked about some really specific examples. There's a question here from Susan Allen about how do you collect and track your survey and your complaints when you have so many multiple departments or locations to deal with? How do you kind of keep track of all that when you're responding to service recovery?
So we're lucky. We were able to afford a tool called Salesforce that allows us to capture all of it. So if you have ever touched anybody in our organization, we're going to know about it. And we're going to have that data, and that's going to be linked to that patient for here until eternity. So that was something that I couldn't get many things, but that was one thing they were able to get. So it allowed us to see the complaints. It allowed us to see the opportunity. And even without that particular tool, and at another organization I was at, our EMR system was homegrown. So we actually built in an area where we could place all that information. So anyone had access to the EMR could actually upload or put in the complaint, or even things about the patient that we needed to know. So you can be creative with it, but definitely making sure that it was in one repository, a data warehouse or Salesforce, and then being able to look at trends, and we could find those trends if we were seeing it in different markets. And because we had the patient population, the patient's info, we could even break it down by ethnicity, race, zip code. Are they all saying the same thing? Is there something going on in this clinic? Is there something going on with this provider? So it really did help us to stratify data.
That's very helpful tips on how to manage that process. I'm going to ask a question for both of you to think about. It just came in about a very interesting sort of connection between patient experience and patient safety, and whether you find that one can inform the other, or do you deal with those as two separate concepts? And I will say that the CAHPS team with AHRQ support last October put on a research meeting which sort of addressed the issue of the relationship between patient experience and patient safety. But it's a very hot topic now, as you know. I'm just curious how your patient experience responsibilities sort of dovetail with or overlap with patient safety issues in your organizations.
So for me, since I've been in healthcare, I actually call it the marriage of necessity.
I see.
Okay. So they cannot be separated. They have to be together. Even when I'm, going to safety meetings, because I actually, I'm a member of some of these safety organizations as a patient experience professional, they can't be separated. You have to leverage what you know in patient experience, and because when I think of patient safety, I mean, literacy is part of patient safety. Right. Yeah. So if the patient if I, as a patient, as an experienced professional, don't understand what literacy is and how to improve it, then how are my patients going to know how to take their medication or be able to be active participants in their care? I share decision making. And so there's a lot of tools that I borrow liberally from AHRQ to improve our experiences from a patient experience and a patient safety. So I sit on all the committees. I am lockstep with the safety officer. So I don't see there being a difference between it. And as a patient, I hope to God it's not a difference in healthcare organizations, that they are together and working in partnership.
Great.
Can I add on?
Sure, please do.
Yeah, so VHA is a high reliability organization. Ensuring and patient experience is another layer. It's not conflicting. It is a complement to the sense where we are delivering a consistent, exceptional experience for all of our patients, and we are doing it in a safe and reliable way. So it is absolutely a nice complement in the delivery of our care.
Yeah. Very good. Nicole, I'm going to come back to you with this question because one of our attendees, Richard Edwards, I think points to the fact that we're talking about, in this case, two large sort of well-resourced organizations, the VA, CareMax. On the other hand, given your experience, Nicole, working with a population that's hard to reach, his question is basically, how do you think about lower cost ways of reaching patients? And maybe this kind of gets back to the multiplicity of feedback methods, but how do you get to community clinics where the resources are very limited to reach their members, ideas for more inexpensive, sort of low-tech approaches? Do you have any thoughts on that?
Oh, Richard, I trust me, I feel you on that one. So CareMax is, compared to my healthcare plan, multi-billion-dollar healthcare system, money for days. Not so much on the provider side, especially clinics. So for journey mapping, I got some books on eBay and Amazon and taught myself how to do it. As for surveys, AHRQ has the CAHPS survey questions on the website, how to administer it, all best practices. And that's exactly what we used. So we leveraged people that were internally in the organization to help us make the phone calls for staff we wanted to keep. And then we leveraged free tools in order to send the survey out via email or text. So we tried to do high value, low costs across a lot of the things that we were doing with our patients. Even M.P.A, we did it at the point of service. It was very simple. It was something we baked into the EMR as the patient was being discharged. So I think there's a lot of opportunity to capture patient voice and be able to synthesize that information without using a lot of money, because we worked with a lot of managed shared organizations and in the healthcare plan world. And those were clinics that might have had the wife was a front desk person and the husband was a doctor, and that's it. Right. So, but they wanted to know voice of customer. And so we would create tools for them that they could easily use a paper survey at the point of service. They may not have had the money to have the technology. So there are a lot of ways for us to capture that information and still make it effective without spending a lot of money.
Mm-hmm. Very good. We're kind of nearing the sort of the wrap-up part of our webcast today. And Caren, do you have any other questions you want to field to our panelists before we move to a couple of closing questions?
Let's go to the closing questions. I think you're asking all of the questions that I would have asked.
Okay.
And thank you to the participants who submitted these questions. They're great, excellent. And this is a fascinating discussion.
Absolutely, I couldn't agree more. So just as kind of a stepping back, we kind of started with the big picture and then got some, really sort of specific questions with some detailed answers. What would you say, and Donna, will start with you, in terms of kind of key lessons or takeaways you could sort of impart to our audience in terms of all the kind of experience you gathered about using multiple methods? Are there one or two sort of key lessons or sort of recommendations you would make?
First and foremost is listen to the voice of your customer. And if you're not already asking your customers for additional feedback, find ways to do that. Whether it's go to Gemba, leadership rounding, shadowing, secret shoppers. There are so many ways to get additional data to complement what is coming in through your surveys. And I feel like we've barely scratched the surface. And so first and foremost, do more to get additional customer voices. Focus groups, interviews, etc. The second one is VA's adopted the ProSci change management model, which has really helped us leverage.
Can you say that again?
ProSci change management. ProSci is the company. The change management model is a model to guide organizational change and guide people through those changes. And for us, it's been an influencer on leveraging with evidence-based process improvement techniques such as lean. So when we use them all together, we see more success in improving our scores, improving our survey scores. And for us, that also goes along with education. So educating employee on the data, on the CAHPS, on the surveys themselves, busting those myths, because you cannot over-educate on these areas. There's too many employees and too many patients, so we really need to make sure we get the word of mouth out.
Great, thank you so much. Nicole, parting words of wisdom. You're on mute.
Now, why would I do that? Why would I be on mute? My apologies, y'all. I would say, know your work is rooted in operational excellence and not fluff. Because as experienced leaders, They like to put fluff on us. We are not fluff. We contribute to the ROI of the organization. I just want to put that out there. So discover your KPIs and know your impact and how you impact that ROI. Develop a strategy, not just tactics, right? Because people listen to that. And last but not least, track measurement of process, not the outcomes, right? So when you are going to improve something, whether it be any part of the experience, look at the process, put some KPIs around the process so that, you know, a month or two into it, you're not going like, you're not thinking you're going the right way. And at the end of the quarter, you're like, wow, we didn't make it. At least if you're tracking those processes, you can course correct during that time. And I can tell you, being coming from a Medicare Advantage healthcare plan, a very large one, one of the things that, you know, we did a lot of with our practices that we had, which were not ours, we weren't owned by, we didn't own them, was to provide them with tools and resources so they could do the same thing that I'm talking about now. So whether it be, I used to call it a CXO in a box, you know, give them all the tools that you can collect and help them improve experiences at the practice level, which automatically helped us out at the plan level. So just knowing that this work is not fluff, I think is very, very important. And that will carry you through your process improvement measurements.
Very good. Definitely not fluff. And I think the two of you have really sort of given us a lot of very robust, concrete information and insights and sort of strategies and ideas for how you can take that important charge to improve the patient experience and make it happen in your organization. So thanks again. Mike, let's move to the kind of wrap-up slides. Thank you. For those of you who are not already registered to receive email updates and alerts from the CAHPS program, you can easily do that by going to the CAHPS site, signing up for email updates, and you can just sort of select what you want to receive. And that's exactly the way you learn about these kinds of webcasts or other educational events. And I will tell you that we have one coming up that we haven't even had a chance to promote yet, but mark your calendars for June 5th from 1 to 2 p.m. because we'll be featuring Mark Elliott from the RAND Corporation. We'll be talking about case mix adjustment and survey mode adjustment, which are two really important aspects analytically for understanding your CAHPS surveys. And why do we do that? Why it's important to do it, and some common myths surrounding those two techniques. That's on June 5th. And we have a research meeting coming up in September. We'll be promoting this in the next few weeks, which will take a look at the relationship between PREMS, patient-reported experience measures like CAHPS, and PROMS, patient-reported outcome measures, how they're different, how they can complement each other. And there's been a lot more interest expressed recently in PROMS, focusing on outcomes. And so we thought that would be an important research meeting, which is open to all of you for attendance. So stay tuned for kind of a save the date notice on that. Next slide, please. We welcome always your questions or comments. We try to address as many as we could, anticipating this discussion through your registration questions and then what you sent in live during the webcast today. But this is other ways that you can reach us by email, by phone, and at our website, www.ahrq.gov/CAHPS for CAHPS. And with that, we're going to wrap up. Again, I want to thank Caren and Donna and Nicole for a really stimulating, thoughtful discussion on patient feedback methods that complement CAHPS. And thank all of you for joining today. And if you take a moment when you exit the Zoom platform, just complete our webcast evaluation. And with that, have a wonderful day and a wonderful spring, and we'll see you next time.